Good morning, everybody, and welcome to the third day of the International Forum on Quality and Safety in Healthcare here in Sydney. I'd like to start by acknowledging the traditional owners and custodians of the land on which we meet today, the Gadigal people of the Eora Nation, and pay my respects to elders past and present and here today. We're going to begin today with a keynote from Don Berwick, who'll be joining us very shortly live from Boston. I hope you had a great day at the conference yesterday and on Sunday for those of you who are here, and you had a chance to meet some of your new connections and some of your older colleagues that you haven't seen for a while. So also, hello to everyone online. We have over 170 people registered online in addition to those who are here with us in the room. And there were so many amazing moments yesterday, starting with the welcome to country and the incredible smoking ceremony to heal and to cleanse. And we heard great speakers from around the world and locally yesterday who were speaking about putting care back into healthcare. We started with Dr. Kedar Mate. And healthcare as a social enterprise. And Ed Shine's theories came up a number of times applied to healthcare as a team sport. The leadership lessons learnt through crisis, particularly the pandemic and the natural disasters that we have been experiencing in Australia. And shifting our thinking in quality improvement in health as an infinite game. And I particularly love this book, The Infinite Game by Simon Sinek. If you haven't read it, I thoroughly recommend it. And a focus on human experience and acting hard and fast, particularly in a crisis, but with diligence. And at the end of the day, we heard from Derek Fairley about building radical kinship and the consistency of purpose. We've got another action-packed day today ahead of us, and we're looking forward to some inspirational keynotes, as well as the opportunity to get hands-on and consider perspectives from around the world that can support and inspire solutions to global and regional challenges. Please make sure you visit the networking area at lunch and the exhibition area to join the Consumer Huddle hosted by Health Consumers New South Wales and the Consumers Health Forum, along with Joy at Work Huddle, which is being hosted by IHI. As mentioned yesterday, we continue to be mindful of the current COVID situation to maintain the safety of ourselves, exhibitors, our staff. Please can you make sure you adhere to the following safeguards that have been put in place. We recommend the wearing of face coverings during the course of the event, except when eating and drinking. Hand sanitising stations are available throughout the venue, so please make sure you avail yourself of those facilities. And we ask you to be mindful of others and to adhere to social distancing where possible when you're moving around the event. We request that participants please avoid physical contact, such as handshakes and embraces, and I know that's very hard when many of you haven't seen each other in person for many years. Also wanted to let you know that we will be evaluating this forum, and a survey will come out via email to all of you who have registered after the event. Now it's time to move on to the main business of the day, our keynote session, and I'm absolutely delighted to welcome the amazing Don Berwick, IHI President Emeritus and Senior Fellow, Institute for Healthcare Improvement. Please welcome Don.
Well, thank you so much for the chance to join you. My heart is hurting for my inability to be with you in person. I was so looking forward to visiting one of my favorite countries in the world and to meeting so many of my friends and joining you there. But unfortunately, unwelcome medical issues have arisen in my family and required me to stay here in Boston. I'm working very hard on you and your colleagues to get an invitation to come back to Australia for some reason very, very soon and spend that time with you. But thank you for letting me join you this way. And I hope you're having a wonderful forum. Since we're in the spirit of health and healthcare, I think I'd like to start with patient presentations. I'm going to present to you two patients. Patient number one is a 65-year-old man. He's very vibrant, he's capable, he's intelligent, but he has very serious health problems, including diabetes. He has incipient kidney failure, chronic leukemia, he has difficulty walking because of a spinal cord injury from a surgical mishap. He recently had a pulmonary embolism and is on anticoagulation. His clinicians this year have included many people, oncologists, nephrologists, endocrinologists, neurologists, orthopedic surgeons, physical and occupational therapists, and primary care docs as nurses, just to name a few. 2 months ago, he got a very disturbing, very worrisome lab report at the end of the day with potentially ominous implications for his future. So he tried to reach a doctor or a nurse to discuss the problem. It took 4 days for him to get a call back from anyone at all. 4 days of fear, uncertainty, confusion, and time on hold on phone calls. This, by the way, was at a major university hospital system. At the same time, he has to make many visits to that system over time, visits to specialists and for tests. Despite his very serious mobility problems, the patient finds himself often going from home to clinic and home to clinic, back and forth several times a week, sometimes daily, every day. No one has ever found a way to bundle his visits more efficiently so that a single arduous trip can include several appointments rather than just going one day at a time. This patient has superb care by some measures, no doubt about it. He's alive because of the dedication of clinicians and the advances of medical science. But by other measures, his care is a mess. It's redundant, it's wasteful, it's confused, it's uncoordinated, it's fragmented. It took them 4 days to get back to him to answer an urgent, worrisome question. The system needs improvement. It needs quality improvement. If you were to ask this patient what the improvement most badly needed is, at that time he would say, please answer my question. That patient, by the way, is my brother. Patient number two is older than my brother. He's also troubled by many afflictions. These afflictions interact in vicious cycles with different groups handling different components of the problem. There's a great deal of science to bring to bear on the components, specialty by specialty, and a lot of good people who truly do care. But there's no system of care, and there's no serious engagement with a plan of coordination. No one seems to be in charge of the care, and fragmentation rules. And time is running out for patient number two. There's a point of no return, and that point is now in sight. Patient number two has lived a very long time, 4.5 billion years, give or take. But the last few years have brought patient number two to the brink. Needs improvement too. Now, patient number two, of course, is my planet. The change is constant. The Buddha teaches us that. And so the work to improve health and care changes constantly also. Since its founding, the central premise of the Institute for Healthcare Improvement's work is that improvement requires two main assets, two main things, aims and methods. Methods count. Specifically, no matter what you're trying to improve, trying harder is not a good plan. Trying harder plans have been around a long time. They have dominated a long time. They still dominate. But trying harder is a bankrupt approach. Methods matter. Aims matter too, by the way, and they also change over time. Unlike methods, aims are not rooted in science. Aims are rooted in values. We get to choose our aims. You can pick any planet that you want to travel to, but you don't have the same privilege when it comes to methods. No matter which planet you pick, rocket science applies. Now, That's a bit oversimplified, of course, in at least two ways. First, some aims lead logically, tightly to other aims. If you want to reduce lung cancer, you better reduce smoking. Science tells us that. And so, as knowledge grows about the scientific connections between causes and effects, our aims change. They should change, they have to change. Conversely, methods are not entirely distinct from values. That's what we mean when we say that the ends don't justify the means. Our values constrain the methods we can ethically deploy. Now, there's actually a very happy convergence, a very fortunate convergence between values like respect, cooperation, equity, openness, values like those on the one hand, and the methods of improvement that have developed over the past century. And I'm going to be saying quite a bit more about that as we go on. Now, when the Institute for Healthcare Improvement was founded in 1991, that's over 30 years ago, frameworks for aims for improvement were far from complete. They were not widely agreed upon. There were important researchers, maverick researchers, people like Bob Brook at the Rand Corporation, Jack Wenberg at Dartmouth, John Williamson at Baltimore, at Johns Hopkins in the US. And in the UK, for example, Archie Cochrane and Julian Tudor Hart and Austin Bradford Hill, many people, many rather courageous health system scientists had made us aware of enormous variation in practice, far exceeding any claim of logic. This is the work, for example, of Jack Wenberg that you may or may not know. Elliot Fisher and Jack Wenberg showing enormous variation in expenditures per capita in the United States for patients. Wenberg showed tenfold variation in tonsillectomy rates in the small rural state of Vermont in the United States, just within that state. Two cities in Iowa, just 100 miles apart, with changes in differences in prostatectomy rates between 15% and 85%. What Wenberg and Fisher showed in their research was that the care you got did not depend on what you had wrong with you. It depended on where you lived. Unwarranted, illogical variation in practice, not distinctly related to outcomes at all. No relationship, in fact, between the patterns of use of care and the outcomes of care. Julian Tudor Hart, one of my heroes, had shown shocking inequalities in health status and access to care, correlating with wealth and with poverty. He called it the inverse care law. The more you needed care, the less likely it was to be there for you. Austin Bradford Hill had argued for much stronger roots for clinical practice and evidence from well-designed clinical trials almost a century ago. And Bob Brook and John Williamson had laid foundations for appropriate care guidelines rather than chaotic, every person for themselves practice. Every man for himself at those days, it was mostly men. If we had been forced in IHI's infancy to state clearly the aims for healthcare improvement that we centered on, they would have revolved around this work. They would have revolved around reducing unwarranted variation in care. The aim would have been to have everyone count reliably on care that conformed to the best science. We would have mentioned also probably access and waiting time so that people didn't wait for their help. And we probably would have talked about reducing complications. When IHI was founded, we would have described patient safety that way, reducing complications. So we had our aims, but they weren't deeply, securely rooted in well-known science right at the start. By contrast, the IHI had very clear vision about the methods for improvement, the how. That was because the whole idea of starting IHI had come from a group of colleagues, our leader was Paul Batalden, who had encountered the groundbreaking scientific work of scholars in other industries who had had nearly half a century of experience, successful experience, making better products and services by employing a cocktail of approaches that could largely be traced back to statisticians and engineers in the first half of the 20th century. Most importantly, perhaps this man, Walter Shewhart. Shewhart had used statistical theory to develop methods of management that allowed improvement to move upstream, as you know, to make processes better rather than just throwing out defective products at the end of the line. Schuhart's methods were much, much more powerful, much more effective, much lower cost than reliance on inspection that preceded his methods. The scholars upon whose methods IHI was founded, including Schuhart and W. Edwards Deming and Joseph Duran, names I hope they're familiar to you. Our bookshelves featured their thinking. We studied their approaches carefully. We adapted them as we went to the peculiar context of healthcare. I must say that adaptation continues today with Paul Vitale's, again, leadership work on co-production, modifying those approaches in response to a service industry. As we learned like that, we added more methods to the IHI toolbox. For example, we added methods of collaboration, like breakthrough series collaboratives. We added technical levers, like driver diagrams and bundles or change packages that you're seeing on the posters that you're viewing at this forum. And we added campaign structures, like the 100,000 Lives campaign, brilliantly designed by my friend and colleague, Joe McCannon. But at its core, IHI's genetic code contains scientifically grounded methods of improvement that were ready, that were waiting for the service of any aim. Now, it would take me many, many hours to fully describe and explain what I mean when I use the term scientific methods of improvement. And frankly, I think that would be wasted time because probably most of you listening to me right now, you know pretty well what I'm talking about. At least you've heard it secondhand. I'm actually a little bit less sure that, like the founders of IHI, most of you have actually gone back to the sources. How many of you have actually read the work of Deming or Duran or Schuhart and their many students? How many of you have read them in their original versions? Perhaps not many of you. Equally, by the way, I'm not sure most of you have met directly the work of the healthcare quality pioneers in the domains of AIM, like Bob Brook and Jack Wenberg on their work on appropriateness and variation. They gave us our very first glimpses of aims for improvement that could really help patients. But that's okay. I mean, you don't have to read Newton's Principia. You can read about Newton's Principia, or you can read about people who read about Newton's Principia. But nonetheless, I'm going to take a minute to touch back to that original work, especially of Deming, and I think you'll see why soon. One of the most efficient summaries of Deming's 6 decades of thought is this diagram, which I think is attributable to a man named Jim Bakken. Jim was not only just one of Deming's closest colleagues, but also a co-founder of IHI. Bakken was head of quality at Ford Motor Company and one of the first American corporate leaders to recognize the power and the challenge of the modern methods of improvement from Schuhart and Deming and others. Jim Bakken was a friend of mine. One day, he told me about sitting around in Dr. Deming's living room. He was trying to understand a kind of new set of ideas that Deming had that he was eventually going to publish in this book, his last book, The New Economics. And Jim Bakken, talking to me, quoted himself. He said, and then I said to Dr. Deming, I think what you're saying is it all comes down to these categories. And Deming, unfortunately, agreed and chose to call this framework profound knowledge. I say unfortunately because that label, profound knowledge, is about as off-putting as any label I've ever heard. But I've come to think of Deming's framework that's crafted by Bakken is profound. I think it's the best summary I'd say I've encountered in my career of kind of a quick way to describe the alternative way of thinking. It's alternative to exhortation. It's alternative to trying harder. It's alternative to wishful thinking if you really want things to get better. In stark terms, let me be clear. The usual alternative to a scientific framework like this one is just yelling louder at people, telling them to try harder, one way or another, telling people to do better, and it doesn't work. Now here's what Bakken and Deming said. This is the diagram that Bakken showed me. They said that in the normal pursuit of improvement, of getting better, You grow subject matter knowledge, disciplinary knowledge. If you want to be a better surgeon, you should learn surgery. If you want to be a better pharmacist, you should learn about medication. Absolutely, yes. I definitely want my surgeon to know exactly where my appendix is and exactly when and exactly how to remove it. That's traditional subject matter disciplinary knowledge. If you grow it, you get what they call traditional improvement. But Deming asserted, along with Schuart and Juran and dozens of other scholars, this is a deep, deep tree of scientific foundations, scientific contributions to one way to think about how to get better beyond traditional improvement. They asserted that growth of this discipline knowledge will not achieve continual rapid improvement, especially not in what we'll call a complex system. In a complex system, the components, including us, including people, we are highly interdependent. Cause and effect relationships are not linear. The effects can be remote in time and space, where the future is very uncertain, where you have to adapt continually in order to progress. That won't work where textbooks fail because the future has not arrived when they are written. You cannot use disciplinary knowledge to grow improvement because the future hasn't arrived. That's a deep thought, but you can understand it right away. There's a very big difference between understanding bicycles and learning how to ride a bicycle. They are not the same improvement enterprise. One is fixed. You could understand a bicycle by reading a book. You cannot learn to ride a bicycle by reading a book. Other kinds of knowledge are required to support improvement in a complex world. That's the profound knowledge that Deming was unfortunately labeling that way. It's profound in the sense that it can adapt and change. It's about learning under conditions of serious uncertainty into the future. Every child does that. I'm in touch with you from my home, where right now my two of my grandchildren are staying with me, 5-year-old Naomi and 18-month-old Sadie. Sadie, I was having dinner with her tonight, and I was watching her learn to use a fork, and it was an incredible experience. She kind of got there. By the end of the meal, she could navigate the food into her mouth using a fork, which is not a very simple task, but she didn't do it by reading about forks or by studying the subject of forks. She did it with this dynamic process of trial and exploration and watching me eat and copying. That's profound knowledge in action. The 4 categories in which Bakken codified Deming's explorations were these. And as any of you know who spent time in an IHI course or heard from Bob Lloyd or Lloyd Provost, the other master teachers in the IHI family, you know this list. First, knowledge of systems. You have to see systems in the first place, understand the dynamics of them, how they act in complex, very hard to predict ways. You've heard about this. It's like the famous butterfly effect from chaos theory, in which a very, very small change can have unpredictable consequences, very remote in time and place. You have to have knowledge about interdependency. How do I affect you? How do you affect me? How does A affect B and vice versa? You have to knowledge about the seductive and destructive character of suboptimizing a part of a system at the expense of the rest. We do that all the time in healthcare, sectoring off operating rooms for the orthopedists, or 2 to 6 in the afternoon is the time for X. We continue to suboptimize components. That's not systems thinking. Rugby teams don't win because each player does his best alone. They win because they pass the ball. Knowledge about causes and networks of causes is systems knowledge. You may think, doctor, that you are the system. You are not the system. Knowledge about recursive, effective ways to improve systems is an essential resource for improvement. That's the first component, knowledge of systems. The second is knowledge of variation. We measure all the time, we sense all the time, but how do we use the measures? How do we interpret variation in the measures? Can we tell the difference between a random change, a change we call attributable to common causes or properties of the system itself, and non-random changes with special causes from outside the system, not characteristic of the system, but very instructive. And we know how to act when we see each kind of variation. The third component of this framework is knowledge of psychology. This is a rather difficult category. It's really a potpourri of topic. It has to do with group process, conflict resolution, motivation theory, adult learning theory, cognitive psychology, and that's just a few of the topics under this rubric. If there's a unifying theme to knowledge of psychology in Deming's world, I think the theme may be cooperation. How can you achieve synergy, shared intent, appropriate collective action in a terrain of uncertainty and complexity? Fragmentation is the enemy of excellence. It's the enemy of improvement. Cooperation is its best friend, and that's a psychological statement as much as a technical one. And the fourth category is a little harder to describe. It's knowledge about how knowledge grows. It's what my granddaughter Sadie was doing tonight. Knowledge. How did she grow the knowledge of how to use a fork? She had she used improvement, although she can't even talk yet. She learned in a terrain of complexity and uncertainty over time. Now, the icon the central image we use in this field is PDSA, the Plan, Do, Study, Act cycle. That's a much more powerful, much more profound idea than it looks at first. What PDSA does, it encodes a continual lifelong attitude about learning. It's the attitude that says try, then reflect as the key to growth. Every child knows that. Sadie knew that tonight. To ride a bike better, you have to get on the bike. But what is native to individuals, all of us, to healthy children and healthy adults, this learning by doing, is not native in organizations or groups. Having an organization in which try it and learn is the culture, it's the bias. It requires humility, it requires tolerance of failure, it requires mechanisms for mutual endeavor, it requires time to reflect, it requires a willingness to share, and any and all of those may be in short supply in stressed contexts where change feels unsafe and where leaders don't understand systems. You know, as I watched Sadie learn to use her fork, when it didn't work, when she dropped the food, she laughed. She was having fun learning. Leaders have to know that, and they have to think also that trying harder is not a good plan. So when in the rest of this talk, when I say science of improvement, I mean Deming's 4 categories of knowledge for improvement: profound knowledge, if you can pardon that term, wedded to the subject matter knowledge to produce continual improvement. In addition, thanks to our IHI's 20-year or more collaboration with associates in process improvement, Lloyd Provost and Ron Moa and Kevin Nolan and Jerry Langley and the late Tom Nolan, we also mean, when we say science of improvement, we mean using the associates in process improvement model for improvement. It's a way to harness this way of thinking about systems and variation and psychology and experimentation into an action plan. So the model for improvement, which hopefully many of you know, it's a guide. It's a kind of little trick for guiding you through steps that will allow you to implement the perspective of profound knowledge. I suspect many of you have seen this. It's spread worldwide. It's really good. It's not the only thing of its type, and there are other good models, but we use this all the time. I use it all the time. It's not the gospel. Other models can work too, and I'm sure you might describe yours, but this one's particularly user-friendly and efficient. It's a common language you can use to apply science to processes. You get yourself an aim, use a fork and get the food in my mouth. How do I know if a change is improvement? See if I drop the food this time. What change can I make that will result in improvement? Oh, Papa just showed me to hold the the other way, and then try it out. And yep, food's in my mouth. Plan, do, study, act. This is a common language for profound knowledge in action. When I say scientific improvement, I mean trying to make good changes guided by the lenses of profound knowledge, systems thinking, understanding variation, working collaboratively, and trying tests of change, all practiced with the help of the model for improvement as a template. Now, up to this point, I could have given this talk 25 years ago, but there's very little new in it. I probably did give it 25 years ago. My memory's not so good anymore. But in the meantime, something's changed. Something changed big time in healthcare, which I'm going to talk about. The aims have changed. It's not exactly. The older aims are still with us. The aims like reduce unwarranted variation, reduce patient injuries, reduce unwanted delays, things like that. They're all as important as ever. Ask my brother. These aims, they were canonized sort of in 2001 in the Institute of Medicine report, Crossing the Quality Chasm, as the 6 aims for improvement. Safety, which had been written about in the prior report, To Err is Human. Effectiveness means following the science in your practice. Patient-centeredness, what matters to the patient, that is our guide. Timeliness, reduction of delay. Efficiency, reduction of waste, and equity. All 6 of these aims are still with us. They're hardly solved. They all matter. And I will editorialize to say, we in IHI feel strongly that safety has fallen off the screen too far, and too many hospitals, too many systems are no longer have safety centered where it needs to be. That is changing and not true any longer in Australia. We're excited about what's going on there to get safety back at the strategic center. But in 2022 now, these 6 aims may seem a little quaint, a little incomplete, because nowadays we have other preoccupations, 2022 preoccupations. These were frankly not on the main screen when the Institute of Medicine Committee was meeting in 2001. Let me give you 5 examples. First, equity. Wait a minute. Isn't equity one of the 6 aims in the Crossing the Quality Chasm? Well, yeah and no. I was in the room when those 6 aims were first written down on a flip chart on the 2nd floor of the National Academy of Medicine's Woods Hole, Massachusetts Conference Center. In fact, I'm the one who wrote them down. And yes, equity was there. But Black Lives Matter was not. George Floyd's murder was not. We knew the civil rights movement in the US, but we did not know, rather we did not fully grasp how far our nation truly was from racial and social justice. We should have, but we didn't. For you in Australia or any other country listening to me in the room, you need to make your own decision about what form inequity it takes in your context. We certainly know what it is in the US, but we didn't place equity for health and healthcare in the, I would say, the preeminent position among aims for improvement that in retrospect we should have. And I will credit my colleague, Kate Armate, for bringing equity forward for IHI at a new level, as Derek Feely did before him. Second, climate change. Global warming was actually well underway when the Chasm report was written. The evidence was accumulating that it might overtake humanity in some distant time, might even destroy the planet eventually. But we didn't know in 1991, or frankly in 2001, we didn't have any inkling that 20 years later, the World Health Organization would declare climate change to be the most significant single threat to human health in the world. We didn't know that the IPCC, the Intergovernmental Panel on Climate Change, would be giving the world notice that irreversible destruction is around the corner unless we change our ways. We didn't know that healthcare produced 8.5% of the greenhouse gases in the US, and that we in healthcare were deeply involved in climate change in 2 directions, as cause and in dealing with the effects. We know now. Pandemic preparedness. Few people saw the pandemic coming, and we did not in 1991 or 2001, when IHI was founded or when the Chasm report was written, have any clear idea that healthcare needed to improve its capacity to deal with and prevent 21st century threats of that massive scale. Now, COVID has grabbed us by the collar and forced us to realize that public health really matters. Workforce burnout, we did not know, I don't think we could have imagined the shortages and physical and psychological damage that our healthcare workforce is now living with. Who could have guessed in 2001, let alone 1991, that we would see we would be millions of nurses behind our needs, or that in some surveys recently, 1 in every 4 American doctors says that they plan on leaving the profession within the next 2 years. Who knew that? And then social determinants of health, social influences on health, which you heard a lot about already in this meeting. In this case, we did know. A century of research had already documented that the causes of health and illness lie outside healthcare. As Lord Nigel Crisp has written in his terrific book, Hospitals are for repair, home is for health. But in its early years, the quality movement was attended almost exclusively to the care system, not the health system. That has changed. IHI now has health production squarely in its headlights, though without abandoning the pursuit of better care as well. The 6 aims still matter. The triple aim, which was brought to the world by my IHI faculty colleagues, Tom Nolan and John Whittington, they're the authors. The triple aim, better care for individuals, 6 aims from the Institute of Medicine, better health for populations, health is made at home, and lower per capita cost. We can't afford the waste. They articulated that balance in 2006. Credit to them. Now, thank goodness, people have passion for these newer health-related foci. Thank goodness. Now, equity, climate change, preparedness, burnout, and social influence on health are on the screen, appropriately so. They are important. They earn headlines. But they're different. They're different because they have very sharp political edges. They court conflict. Some of these areas of aim are interwoven with identity politics. They suggest difficult, contentious redistributions of wealth and power and investment, both within nations and among nations. As important as healthcare improvement is, healthcare improvement codified in the 6 classical aims, safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity, as important as those are, and it's very important, healthcare improvement did not, in its earlier forms, have to face the passions, the conflicts, and the politics like we see for these 2022 aims. Patient safety, evidence-based care, even patient-centeredness, these didn't raise blood pressures too much. They did not invite hurled accusations across left to right political divides. They didn't pit generations against each other or races against each other. They demanded attention, but generally they didn't demand that much redistribution of wealth or power. And that, I'm thinking lately, creates a problem. And this is the problem I wanted to bring your attention to. I may be wrong, but I think that the newer aims, which are so full of conflict and public drama, they can and they do distract us from methods. It seems that the more we're moved by the passion for these big aims, climate change, equity, the less patient we become with the methods for achieving those aims. That's a bit of a paradox, because here's what it would mean. It would mean that the more urgently we feel about the problem, the more urgently we need the method, the less time we have for the method, because we're being distracted in a way or exhausted by the passions. I'll phrase that as a question. Can the scientific methods of improvement, of quality improvement, that I have reviewed briefly with you in the early part of this talk, can these help achieve gains in this new terrain, climate change, equity, sustainable workforce, pandemic preparedness, and social determinants of health? Do the methods matter here too? Spoiler alert, the answer is yes. In fact, I further suggest that if we simply revert to try harder, the old plan, for advancing the new aims, it will be impotent. It'll be as bankrupt as the older pursuit of improvement. We need the passion, but we need to bring disciplined science to the new social demands with all the will we can muster. Now, my brother, patient one, his name is David. It's not too difficult to identify improvement projects that would make a ton of difference to his health, safety, psychological well-being. His specifications, his aim would be, talk with them, they're very simple. His improvement aims are answer the phone, talk with each other, and remember me. And if anyone in a leadership position at that famous healthcare system decided to give those aims priority, he or she would have at their disposal Deming's methods, the 4 elements of profound knowledge. These could be nurtured, implemented every single day by every single person in the system. Systemic knowledge will be manifested, for example, in inquiry and planning for the flows and the designs that are capable of rapid response, reliable coordination, and recall. The current flows and designs are not capable of those. 4-day wait for a callback. Knowledge of variation would be manifest in very simple metrics. They would be correctly interpreted, metrics of system responsiveness. They would know that my brother waited 4 days for a reply, that he suffered needlessly as a result, and they would know why that happened. Knowledge of psychology would nurture teamwork, local experimentation, high priority on cooperative operations. And PDSA cycles would be everywhere, trying to and reporting back on lessons from changes based on queuing theory, on small scale tests, and with sufficient time for people to innovate and explore together the way Sadie explored eating with her fork. I personally think that the healthcare improvement movement has lost touch with much of this scientific heritage. I think people, maybe you, people who care a lot about and want to nurture improvement should take a pause and sometime maybe go back to the science, check to see that you know it and that you use it. The classical scientific knowledge about improvement methodologies matter, I think. The aims are not enough. That's just wishful thinking. For those of you who believe me or want to follow it, I have come up some time ago with a reading list, and I'm going to take a little detour here. I'm sure this will be available online after my talk. 6 books that I would recommend you read if you want to return to the scholarship of our field. For your possible amusement, here they are. Peter Senge's amazing book, now almost 30 years ago, The Fifth Discipline, which is an extensive exploration of the nature of systems and in a completely digestible, in fact, fun to read form, The Fifth Discipline. The Improvement Guide by the Associates in Process Improvement, Jerry Langley, Tom Nolan, Kevin Nolan, and their colleagues. This is the best single manual I know about how to apply the scientific theory of profound knowledge, excuse the expression, to action. This is where the source of that API model for improvement can be found. It's a wonderful, wonderful book. Overcoming Organizational Defenses by the fabulous scholar Chris Argyris. Chris Argyris wrote much about the psychology element of profound knowledge, although that's not the term he used. This is one of his many books, a short, simple one about the psychology of cooperation and other issues in organizations that have trouble getting into a learning mode that my granddaughter Sadie is already in. Carl Weick and Kathy Sutcliffe have written the best single digestible book about high reliability. It's called Managing the Unexpected. Weick is the grandmaster. He's the founder of the field of high reliability. And Weick and Sutcliffe's book, Managing the Unexpected, again, very short, readable. He gives you the foundations for extremely high reliability, which is a foundational scientific area of modern improvement. I love Donald Norman's book, The Design of Everyday Things. This explains human factors. It's a systems thinking book about human factors in performance, and it breaks open the trying harder myth and then talks about how you can actually make systems in which good people can succeed. And then the grand dean of the field of human error, Jim Reason, is still alive. Jim's book, Human Error, which was the first book-length treatment, I think, of human error and its manifestations and causes, is still the best. And so that book, 6 books, The Fifth Discipline, The Improvement Guide, Managing the Unexpected, Human Error, Overcoming Organizational Defenses, The Design of Everyday Things. That's a lot, but what? One book every 2 months for a year? I think you can do it. 40 years of my experience in this field makes me certain, beyond any reasonable doubt, that my brother's care could be vastly better. And by the way, much less expensive. If the good people managing this care actually used improvement science with intentionality. Effective. What about my planet? Patient number 2, does improvement science actually have anything to do with its needs? And what about equity and pandemics and social determinants and the rest? Well, we actually don't have to wonder, because some are already proving the case. And I'm going to give you 3 examples of these methods in use in these new aims for 2022. First, Scotland. Way back in 2012, my colleagues, Derek Feely and Jason Leach, were rising to real expertise in the improvement science as leaders of the Scottish National Health Service. They were applying scientific improvement at a national scale in a way that no other nation has done, I think, before or even since. Their topics were classical. They focused largely on patient safety and evidence-based care in healthcare, and the results were excellent, but they didn't stop there. Derek and Jason and their colleagues, they're not alone, they would be the first to tell you, they saw the potential in applying the same methods to social determinants of health in sectors very far from health and healthcare. And what came out of that thrives today as the Leadership for Improvement team in Scottish government, still supported by the NHS in Scotland. I recently spoke to Stuart Duncan, who's deputy director of that team, and he brought me up to date on some projects ranging from projects in criminal justice reform to health equity to climate change. In every case, his team is building scientifically grounded improvement skills and projects with communities, with other public agencies and local boards. He describes themselves as a small team of qualified improvement advisors who support public policy officials and delivery officers in their improvement journey. He says, we don't just teach. Our evidence shows that teaching is not enough, nor would it be for Sadie and her fork. We also coach and mentor improvers along their individual improvement journeys until they tell us they get it. We continue to be funded entirely by the Scottish Government Health and Social Care and focus on system improvement, but they're way outside healthcare in their work. We've honed in on people and organizations that have the greatest impact on improving equity and reducing social inequality. It's well worth your studying this journey. It's a remarkable journey. This is hard to read. I'm showing to you so you get curious and track it down. It's the Flower of Scotland diagram that Derek and Jason presented at the IHI BMJ International Forum in Glasgow in 2019. The range of applications of quality improvement methods is absolutely breathtaking. The overarching aim, to me, is really tells the story: to focus on creating a more successful country with opportunities for all of Scotland to flourish through increased well-being and sustainable and inclusive economic growth. This invites a pinnacle of systems thinking, and it knows no limits. This work has extended recently to reduce psychological trauma to victims, to young children to become involved in court cases, as well as rape victims. They've assigned improvement advisors to projects in the emerging work program in Scotland called Getting It Right for Every Child, Keeping the Promise. Consciously, they now extend the work into what they call the 3 C's, child poverty, COVID recovery, and climate. This is absolutely world-class scientific improvement competence with expert support methods, the methods we're talking about, brought to bear on major social aims under the banner of national government. Anyone who says that bold 2022 aims and world-class improvement science can't be brought together at scale, they have to now face Scotland as proof of concept. I'm sure Derek and Jason can tell you much more. Another example of improvement science brought to scale on systemic problems is astounding work at the Hospital Sírio-Libanês in Sao Paulo, Brazil. This is stunning. It's led by a senior nurse, Vânia Baia. That hospital has centered workforce well-being in its strategic agenda, using quality improvement every single step of the way, coached by my IHI colleague, Dr. Paulo Berwick, and his IHI team. I've rarely seen an example of, at this scale, total organizational transformation such as Vânia is now able to report. Vânia and her team, they've used IHI's Joy in Work framework, which you can get, it's online from IHI, and they brought every single element of this rather complex framework to bear on systematic projects, first in a pilot intensive care unit and now organization-wide. They began with participative management as the keystone, and they reached to every single work unit for ideas of what matters to employees, and then they work on those ideas. This is very much like the search for and removal of pebbles in the shoes that Tate Shanafelt and Steve Swenson, in this wonderful book from Mayo Clinic, urge in their model of workplace improvement, which is also relevant to the National Academy of Medicine's recent report on taking action against clinician burnout. Shanafelt and Swenson have a very well-developed model focusing on improving agency, coherence, and camaraderie, the three core cultural characteristics of the experiences of the workforce that lead to a sense of pride and joy in work. Agency, that I can be effective; coherence, my work matters, it's important, it has meaning, it adds meaning to my life; camaraderie, which is we do this together. And of the four elements here, which you can read about in their book, one of them is removing pebbles, which is asking people what's in their way that gets in the way of their work and then systematically removing it. This is quality improvement at scale. In Vânia's case, approaching the workforce at the hospital, they were able to identify dozens and dozens of suggestions from the workforce that were then implemented systematically as they studied what the workforce found was bugging them. 93% of the changes suggested by the workforce for removing pebbles were implemented, and the results were real. A joy in work soared by systematic measures. They applied it to dozens of areas of workplace quality aims, and the results speak for themselves. They've expanded now to 87 clinical areas and 244 work groups. And the metrics of success are astounding. The workers lead the projects, the leaders actively support the projects, and the scale is immense. I just asked them for, this is just slides showing the different teams, worker-centered teams on all of the topics for improvement of work life that have arisen. What Vânia determines is what prevents joy in work in the organization is not the difficult or sad moments that everyone experiences. We have hard jobs. It's the systematic conditions of the invisibility of the healthcare worker. IHI is working with Vânia and will over time bring this work to scale. In Brazil, they're going to 100 hospitals in Brazil, and with IHI, I hope and believe with the leadership of the IHI team, global spread of this amazing work. IHI is using improvement science in its Pursuing Equity program, which now involves dozens of healthcare systems. A star among them is the Montefiore system in New York, Montefiore Medical Center, which is a participant in a very difficult, very stressed social area, using the subject matter framework from the National Academy of Medicine about improving equity and access in communities, and then systematically applying it through improvement cycles at Montefiore, day after day, area after area, time after time. It begins with detection, and this shows improvements they've worked on in detecting and in screening people for challenges in social determinants of medicine, soaring rates of detection in the post-COVID period, all through systematic improvement of screening. And they have linked this to a referral system, which allows them to take the detected social problems and refer them for help through a whole set of channels of support for housing, housing availability, housing quality, utilities, money for food, healthcare transportation, healthcare costs, child or adult care, legal help, threats to safety. They have done it through developing human capacity with a workforce, including provider champions who lead the detection and intervention on the social determinants of health, all within the framework of an academic medical center. If you think you can't take modern improvement methods and apply them at scale to big 2022 problems like climate change and equity and workforce burnout and the social determinants of health, you have to take a look at these places. I know this most of all as an American, by the way, who's still reeling from a prior federal administration that was far worse than incompetent. It was mean, deeply dishonest, plagued by destructive political opportunism and failing to confront inequity in my country. I know that improving social systems as big as those affecting climate, the workforce, the social influences on health, preparedness for 21st century threats, and vicious inequity rooted in racism in my country, it's no task for the naive, no task for the timid or the callow. To restore justice in my nation and in this very unjust world is a political agenda. It will require conflict and courage. It depends on passion and caring and commitment. We need moral aims at the center of our work more than ever. But these systems that have gone awry, the systems that have been driven awry, systems that now support rather than mitigate the threats and divisions that could, in all honesty, doom our species, the systems that support inequity, the systems that support greenhouse gas emissions, the systems that support inability to invest in public health. These systems need change, and the will is not enough. They need change, and that change has to rest on scientific foundations. There is subject matter science, to be sure, climate science, the epidemiology of inequity, the dynamics of disease, sustainable work, the dynamics of healing. Translating that knowledge, if we can find the moral will, it will demand the best in our skills to manage change and learning as we go. I am angry about these problems, and I want to fight for justice and respect for the future, for the planet, for the silent, for the excluded. I want to fight for strong, true health in the public and a future for our children. I care about that and will fight politically, but I know enough about change to realize that that anger is just a starting place. The methods still count, and we're going to need the wisdom and patience to navigate to designs and redesigns in which we can then thrive as a more unified, more compassionate, more resilient, more loving community. So we have the skills to do that, and I want us to use them. Thank you very much for the chance to spend this time with you.
Thank you so much, Don, for that amazing presentation, for starting with the story of your brother David and with the case of the world. Trying harder, reminding us that trying harder is not a plan, and particularly the fragmentation as the enemy of improvement, and lifelong learning and the importance of that for us all. Placing equity at the forefront in quality, such an incredibly powerful message, and pushing us to ask the question, Can the scientific methods of quality improvement be applied to the current challenges that we face? Thank you so much for your time, and I particularly want to wish you all the best and to your family as well. Thank you, John. Join me in thanking John again. So don't forget to join us back here later today at 4:15 for our final plenary speaker of the day, Mary Freer, and the Compassion Revolution. And now, time for coffee. The next session will start at 11 a.m, and please have a great day. Thanks, everybody.